Hi guys, welcome back to the channel. Thanks for listening. Today I'm going to be talking about some common topics for the med-surg class review that I did back when I was a peer tutor for the school. So for those of you that don't know me, my name's Kevin. I'm a recent new grad and I graduated nursing school with a 4.0, and these are these little videos I like to make to help make the content more easy to digest and only focusing on the big highlights of nursing school. So like I kind of hinted at in the intro, this slide deck that I'm presenting off of was something that I made as a TA. So we're going to be going over some topics that came up on the first exam. Now keep in mind this PowerPoint was over 120 slides long. I'm only going to be presenting the first two chapters here today, okay? So the first topic is diabetes, okay? A very popular testable topic, especially one that came up often in the med-surg class that my university taught. So we're going to first try to differentiate between type 1 and type 2 diabetes, okay? Now, these are the ranges for normal blood glucose I had when I was a student. We went with 70 to 110. I know in the hospital that I currently work at, we go 7 to 120 is fine and acceptable, but it really depends on where you're at and the hospital you're working with in the future, so make sure you follow their policy. But for purposes of my school's exams, we knew 70 to 110. So type 1, it is an autoimmune disease which the body attacks its own beta cells produced in the pancreas, right? And there's no insulin production. It's a rapid onset. You often see it when early development, so you see it in kids a lot, okay? And then the classic signs of type 1 diabetes are the polyuria, polydipsia, polyphagia, which means you're peeing a lot, you're always thirsty, and you're always hungry, right? There's also weight loss, and there's weakness and fatigue. So very kind of general symptoms, except from the classic 3, right? Now, type 2 diabetes is that the pancreas is producing insulin, however, there's not enough being produced, right? Or the body is resistant, so it's more like insulin insensitivity. And it's a gradual onset, right? We learned throughout studies for the previous few years that it's due to like lifestyle, unhealthy eating, right? It's not something that you're genetically born with like type 1 is. Now, the signs and symptoms are also very similar. You have the classic 3 Ps, the polyuria, polydipsia, polyphagia. But there's also the non-healing wounds and prone to infection and vision alterations. Why do we have vision alterations? Well, it's because there's eye damage to the blood vessels due to the sugar. So basically the sugar in your blood kind of acts like shards of glass, basically, because of the crystal structure, right? And it kind of cuts the vessels, leading to vision alterations in diabetes. But the main key takeaway is recognizing that the 3 Ps are the clinical manifestations for type 2 diabetes, right? There's the polyuria, polydipsia, and polyphagia. Now there's other types of diabetes. Pre-diabetes is usually the precursor to developing type 2, and it's usually asymptomatic. However, long-term complications are still in effect. Some things that we want to enforce on the patient, such as the teaching part of it, are early screenings, signs and symptoms, risk factors, and lifestyle modifications, right? So if you have genetic family history, or if you sit down all day and you don't work out, you don't eat healthy, these are risks, right? It's not necessarily saying that you will get diabetes, it's just a risk. Now there's also gestational diabetes, where it happens when when a woman is pregnant, and that's a bit more for labor and delivery, which I can go into, but usually it's only diagnosed after a certain number of weeks along that pregnancy, and it can have lasting effects after pregnancy, which the woman can become diabetic after. But that's for more labor and delivery. This is just a med-surg kind of overview, okay? So we're going to talk about what happens if you don't control your blood sugar well, right? Because it's going to swing up or it's going to swing down. So that's hyper versus hypoglycemia. Signs of hyperglycemia, when you have too much, right? It can be asymptomatic, but you also have the 3 Ps again. You're going to have blurred vision, headache, right? My fellow student who wrote this put DKA and NHHS, which I believe stands for like not hyperosmolar lality. There's like different names for it. Like my hospital calls it honks because it's non-keto. Um, high blood sugar, but those are more of a result of the high blood sugar. It's not really a sign and symptom of it. Okay, it's more of a result. But yeah, the blurred vision and the headache do happen because of the elevated sugar levels. And DKA, I can go into more of this when we talk more about critical care, but that is when the body is not able to process um, the glucose, and they end up using ketones instead, leaving you in this acidotic state in the body. And they have like Kussmaul's breathing, which is a type of breathing pattern, and they also have this fruity breath. Um, Treatment of that is really focused on in critical care, but not so much for med surg. Okay, so we're going to move on to hypoglycemia, which is the low blood sugar. Now this is the side of the spectrum where it's more medically of an emergency, I would say, because hyperglycemia is not good, but hypoglycemia is much worse because they can go into a coma and potentially not wake up. You have the slurred speech, the vision alterations, anxiety, altered level of consciousness, being diaphoretic, pallor, they're shaky, and they generally don't look too great. Now, the trick I used in nursing school to memorize this was that cold and clammy needs some candy, and warm and dry, sugar high. That's how I remembered whether it was hyper or hypo, because a lot of the signs and symptoms were kind of similar, especially like the headache can be presenting in both. Um, it's also important to remember that during athletes or people who play sports, a quick carb snack every 30 minutes into a workout can prevent and reduce the hypoglycemic episodes, because when you are working out or playing a sport, it increases your body's demand for sugar. So to make sure you teach your patients who are diabetic to replenish their carbs every once in a while throughout the workout. Okay. Now, like I said, hypoglycemia is the more dangerous of the two, and there's the treatments of it. There's the 15-15 rule, where you want to give 15 grams of a quick carb snack, and then you wait 15 minutes and you check the blood sugar again. And if it's still bad, you want to call the primary care physician or whoever is, like the attending, or whoever, like the resident is on call, whoever you need to call, basically, right, to get the doctor. But I want to forewarn you guys with this aspect, this little test taking trick is to make sure that you are really reading the test question. Because if the patient is unconscious, we're not going to give them 15 grams of a quick carb snack. We're not going to encourage them to drink orange juice or any of the common things you may have heard, okay? Because if they're unconscious, they're not going to be able to swallow, and anything you introduce into that oral cavity can lead to aspiration, which is dangerous, right? So, which is why when they're unconscious, you want to go routes like the IM, glucagon, or the glucose gel, or you do dextrose through the IV. Basically, you want to try alternative methods of making sure they get the sugar instead of having them eat something, because the aspiration risk. So make sure you really read the question carefully. Now, how to monitor and manage their blood glucose, right? The most reliable check is the hemoglobin A1C, because it covers a span of their blood sugar levels within 2 to 3 months, right? So it gives you a better clinical picture of how well the patient is doing through an extended period of time. The fasting blood glucose test is when the patient has been NPO for 8 hours plus, and the random is when they have been eating for more than, they're not just NPO for 8 hours. So as you can see, they have different values. For the purpose of the exam, I would recommend memorizing them, which is what I did, or I wrote them down on a piece of scratch paper before the exam. But once I took the NCLEX, which I did not really need to write this down, I just mainly memorized this one, and just knowing that 126 was for fasting. The random blood glucose I've rarely ever seen come up on exam questions and all that, so I would say in order of like high yield to low yield, it would be straight down. So hemoglobin A1C first, fasting blood glucose, and then random. And as always, use whatever values your professors have given you, and if you are working, whatever values your hospital goes by. The treatment for diabetes, obviously, we want to try non-pharmacological methods first, right? We want to try diet, we want to try exercise, we want to try weight management. So You also want them to like carb count their meals. You also want them to check their blood sugar via either an insulin, like built-in insulin measuring device, or a finger stick. And you have other medications that you can give them, like insulin, right? Now we're going to talk a little bit about insulin. So there's a bolus insulin that you give, which are usually rapid acting or short acting. Okay, so these things are like Humalog, regular insulin, things like that, right? And then basal is long acting or intermediate, which are things like MPH or Lantus that lasts a long period of time, and it's usually to cover them once or twice throughout the day. So bolus insulin is usually given right before a meal, or like if they have a high blood sugar. So like I said earlier, the Humalog, Lispro, Aspart. Um, a common one to remember on tests is Lispro. The way I remember that is like Lispro, let's go, and then Aspart. Like when people say get your over here, like that's how I think of it. The onset for rapid acting is 15 minutes before a meal, and then short acting is 30 to 45 minutes before a meal. Um, Basically, for the purpose of exam purposes, I would memorize like how long the onset is, but rarely did I ever see this come up on in like um, the NCLEX and stuff. Because even though I know test prep people say to know it, I haven't really gotten like more than like two questions talking about like the onset of insulin. But it's kind of like obvious, I want to say, to a certain point where you can kind of deduce. Like if you just know the baseline is 15 for rapid, you can kind of like guess at like 30 is the next one, right? Because they all come up in these intervals. Now I'm going to move to intermediate NPH, which is intermediate insulin. It has a duration of 12 to 18 hours, which is why you only give it once or twice a day, and the peak is 4 to 12 hours, right? It also has a cloudy appearance, and this is why it's the only one that you can mix um, with the other insulins. And because of this cloudy appearance, which is different from the other insulins, the way you know how to draw up the two insulins if you're trying to combine them into one needle is you do clear before cloudy. So you want to draw the rapid or regular insulin before you draw the intermediate insulin. But I have yet to really see this be done in a hospital. Then you have the long and lasting ones, which are like Lantus, which is the most popular, or there's also Levemir, which I've seen a lot, and they usually last the whole day. There's no peak, okay? So this one you actually, I think, don't need to really measure the blood sugar for when you're giving it. You just, it's a maintenance dose basically, and you can't mix it with other insulins. Now, the complication of giving insulin is that it causes hypoglycemia, and it can also have lipodystrophy, which is like the fat gets like relocated in your body, if I remember correctly. But then again, that's not something tested upon a lot. But the big one is hypoglycemia. Okay, so this is why we always want to check their blood sugar and make sure they're within the range before you give it to them. So like for my hospital, if it's below 70, I cannot give the insulin. I have to contact the physician. Now there's another anti-diabetic medication that's important to know, which is metformin. It's used to decrease insulin sensitivity, and it's as our school taught it, the number one choice of medications for type 2 diabetes, because it does not cause hypoglycemia. I can go more into the pathoform about it later on, but basically it's just it does not secrete insulin. It's just increasing the sensitivity, so that's why you're not at risk for hypoglycemia. The complication is lactic acidosis as like the big one, and then make sure you don't put the patient under contrast media, because it can cause AKI, because the metformin does have some kidney interaction. So this is why you discontinue these medications 2 days before an IV contrast media and 2 days after. So that's very testable. So the big thing you need to know for metformin is the contrast media interaction, and know the time frame of 2 days. Don't use it with patients with liver disease, and then big red flag for kidney disease and heart failure and alcohol use. But the big one is kidney. This is like always related to kidney whenever I see it on an exam. Okay. I was probably going to plan on going to the next one, but we can probably save this for next time because I do feel like this video is already getting kind of long. So thanks for watching. Happy studying. Let me know if you have any questions.